Hi, good evening, all. I hope you all are doing great and preparing for your upcoming INI exams. Uh, so, today's session is about most important MCQs that are asked in OMR subject. All right. So, before going on to the MCQs, we'll first discuss most important topics that are there in OMR subject. Okay. So, I've just summed up most important topics in a table. So we have ulcerative and vesicular bullous lesions in oral medicine. Most important topics. You will get many questions based on this topic. Second one is red and white lesions, say leukoplakia, candidiasis. Then comes OSMF. These are commonly asked lesions or the entities. All right. Then we have tongue lesions, pigmentations, orofacial pain in which we have trigeminal neuralgia, postherpetic neuralgia, Ramsay-Hunt syndrome, all right. And you should be thorough with the clinical features of each neuralgic pain as well as the drug of choice used in each neuralgia, all right. Questions based on oral cancer can be asked, all right. Come on to the oral radiology. We have radiation physics. So, questions will be based on the X-ray tube. All right, production of X-rays, interaction of X-rays with matter. All right, then we have radiobiology, in which you will be asked about deterministic effects, stochastic effects. All right, ideal radiographs, the contrast and density based questions. Which parameter affects contrast or density? Like that. All right, projection geometry, principles of projection geometry, and due to disturbance in the, you can say, the positioning of the radiograph, all right, there are some faults that seen in the radiograph that can be asked as a question, all right. Then we have digital detectors in digital radiography, all right. We have radiographic interpretation like in cyst or tumors, all right, which radiographic appearances are seen in malignancy, then systemic diseases manifested in the jaws, all right, and which appearance is seen in the skull. Okay, in skull radiograph they'll give you the radiograph of skull and they'll ask you this appearance is seen in which diseases, so you should be able to answer such questions. Different appearances seen in fibro-osseous lesions like fibrous dysplasia, Paget's disease, cherubism, all right, that you should be able to answer. Then we have xylographic appearance. After xylography, we take the radiograph, and there are some appearances that you see in particular diseases, such as Sjogren's syndrome, all right, xylodocitis. Then we have benign tumor in salivary gland. So there are some appearances that you should be thorough with. Okay, direct questions will be asked based on these topics. Then we have TMD appearance, temporomandibular joint disorders. Examples say they'll give you a radiograph and they'll ask you this sharpened pencil appearance of condyle is seen in which disease. Okay, so like that you should be able to answer questions based on this image based questions, all right. Then we have advanced imaging. In advanced imaging they will ask you CT units used in CT, algorithm used in CBCT or software used in CBCT, MRI, the magnetic field used in MRI machines, okay, in dentistry, of course. Then PET spect, radionucleotide used in radionucleotide imaging like PET and SPECT, okay, you should know that. Then you should be thorough with landmarks that we see in IOPA radiographs and OPG. All right. So there are some topics which are common in medicine as well as pathology. Okay. So fibroosseous lesions, cyst and tumors, syndromes, different various syndromes, the features they'll give you, and the features are seen in which syndromes. Such kind of questions will be asked. Forensic odontology. All right, so, if you are thorough with these topics, you will be able to answer most of the questions asked pertaining to OMR subject. All right. So, let us start with the most important MCQs that can be asked. All right. So first MCQ is, which of the following is not a high risk factor for leukoplakia? Now, to solve OMR MCQs, all right, we'll underline the keywords, okay, and based on that keywords, we'll find out the answer. All right. So first is, which of the following is not a high risk factor for leukoplakia? So we'll underline this not, okay, not a high risk factor. So options are, first, A, male sex, B, non-smoker, C, DNA aneuploidy, and D, invasive Candida albicans. Now here I'll tell you the answer and then we'll discuss why. All right. This is just a, you can say this factors, high risk factor. You can just memorize those factors and you will be able to answer such questions. All right. So first, option A, which is male sex, is not a high risk factor for leukoplakia. Okay. Second, B, non-smoker. Yes, it is a high risk factor for leukoplakia. DNA aneuploidy, yes, it is a high risk factor for leukoplakia. Why? Because DNA aneuploidy is one of the factor that is seen in the dysplastic cell. Okay, that is seen in the dysplastic cells. Okay, so the cells which shows this DNA aneuploidy have got higher potential for conversion into cancer, higher potential for malignancy. All right. Then D is invasive Candida albicans. So sometimes what happens is these leukoplakic lesions are supra-added with a candidal infection. Okay, then what happens is this candida gets invaded into the you can say lower layers or basal layers of the skin, all right, and that can cause the increased potential for malignancy. All right, so option B, C, and D are high risk factors for leukoplakia. So our answer for this question is first option A, which is male sex, is not a high risk factor for leukoplakia. All right, so I'll give you the table or chart that you should memorize. All right, and then you will be easily answer you will easily answer such kind of questions. All right, so risk factors for malignant change in the white lesions. Patient should have a history of tobacco. All right, so betel quid usage, tobacco smoking or snuff dipping, high alcohol intake, all right, and family history of oral carcinoma are higher risk factors for such patients. Addition to that, okay, if you find if you find leukoplakia or the leukoplakic lesion in non-tobacco user, all right, this is also a high risk factor for malignant changes. All right. Without tobacco habit, if you locate a leukoplakic lesion, it is a high risk for malignant potential. All right. Then we have clinical features, advanced age. All right, old age, old people have got higher potential for malignancy. Second, female gender. All right, first advanced age, second, female gender have got higher risk for malignancy. Third, areas of reddening in the lesion. Say, leukoplakia is divided into two types. We all know that. First is homogeneous, second is heterogeneous. All right. So homogeneous contains white component. All right. White component or wrinkled or you can say cracked mud appearance of the lesion is seen. And heterogeneous contains white and red component. All right. Speckled leukoplakia. All right, example. So, so these areas of reddening or speckling, okay, have got higher potential for conversion into cancer. All right. Next, we have higher risk sites. So, posterolateral tongue, floor of the mouth, retromolar region, and anterior pillar of fossis. Okay, these sites have got higher potential. Okay, so any leukoplakic lesion, if you locate at these particular sites, you immediately order biopsy or go for biopsy in such lesions. All right. Then we have larger lesions, will have higher risk of malignancy. Lesions present for longer periods, longer duration. Okay. Then enlargement or change in the character of pre-existing lesions. Say if you patient comes to you and if you see homogeneous type of leukoplakia, all right, you follow up the case after say 1 month or 1.5 month, you see the red components in that particular leukoplakic homogeneous leukoplakic lesions, all right, you have the red flag, immediately you will order biopsy, all right, because these change in the characteristics of the pre-existing lesions will have higher potential for conversion into cancer or malignancy. All right. And you will order special investigations. You will see degree of dysplasia in such lesions. All right. So just memorize this chart. Just memorize these points. All right. You will be able to answer uh, such kind of questions very easily. All right. Next we have is a 35 years old man reports. Now we'll just underline the keywords. All right. 35 years old man reports with a non-scrapable lesion. All right. On the buccal mucosa with size 5 centimeter. There is a history of smoking for last 10 years. All right. What is the diagnosis and treatment? Now we have got three keywords. 35 years old man, non-scrapable lesions, and smoking for last 10 years. All right. Now we have to uh, mark correct answer with these keywords. All right. So to answer this question, you should know which lesions are non-scrapable lesions. Now they have given options as homogeneous leukoplakia with Levensis retinoic acid. Second, homogeneous leukoplakia treat with triamcinolone. Third, lichen planus treat with Levensis retinoic acid. Fourth, lichen planus treat with triamcinolone. See, now we have two entities here, homogeneous leukoplakia and lichen planus. Now, if you know which lesions are scrapable, which lesions are non-scrapable, so these both lesions falls under non-scrapable lesions. All right. Now, what do we have to rule out other three options? Say, they have again mentioned history of smoking for last 10 years. All right. History of smoking. So there is a tobacco usage there. All right. So we'll prioritize which option? Homogeneous leukoplakia. All right. So homogeneous leukoplakia is there in option A and B. Now we have to choose between these two. Now they have given the treatment plan for homogeneous leukoplakia. All right. First is treated with Levensis retinoic acid. Second, treated with triamcinolone. Now remember one important statement. Okay, very very important statement. Steroids. Steroids are contraindicated. Steroids are contraindicated in leukoplakia. All right. Now, now you should be able to get your answer, correct answer, right? So steroid, that is option B. Okay, option B. We will not mark option B since they have given treatment plan for leukoplakia as steroid. All right. So the answer for this question is option A, which is homogeneous leukoplakia, treat with Levensis retinoic acid. All right. Uh, why we chose homogeneous leukoplakia here? Because they have mentioned specifically history of smoking, history of tobacco usage. Okay. If they would have mentioned some burning sensation and female patient, all right, or Vicom's try, then our answer would have been lichen planus. Okay, but since they have mentioned the history of tobacco usage, our answer goes to homogeneous leukoplakia. All right, and to elaborate more, I have just put up this table of non-scrapable and scrapable lesions. All right, you should memorize this to answer such kind of questions easily. All right. Uh, so in non-scrapable lesions, you have linea alba, frictional keratosis, homogeneous leukoplakia, reticular lichen planus, chronic hyperplastic candidiasis, dyskeratosis congenita, and white sponge nevus. Which are scrapable lesions? We have chemical burn, thermal burn, pseudomembranous candidiasis, syphilitic mucus patch, and diphtheric patch. All right. Next, I have just put up the treatment of leukoplakia. All right. When patient comes to you, you see leukoplakic lesion, you will first advise antifungal because there can be a suprahead fungal infection. Okay. So you will continue this candid cream for a week, 3 times a day. All right. If there you get good response and reduction in the size of lesion, you will continue it for 1 month. If you get no response here and the lesion is less than 1 centimeter in diameter, you can just do excisional biopsy, remove whole lesion. If the size is more than or equal to 1 centimeter, you will go for incisional biopsy. Now you will get a result. We have dysplasia present and we have dysplasia absent. If dysplasia is absent, you will go for antioxidants, that is retinol A, which is vitamin A analog, twice a day for at least 1 month. All right. If you see dysplasia is present, then total excision should be done with a graft. All right. And you should follow up the case for 6 months. Okay. And if excision is not possible, if the site is very vague or you can say unapproachable, then you can just continue with the capsules of lycopene. All right. 4 mg twice a day for 3 months. You can give capsules of antioxidants with selenium twice a day for 6 months, and you can give topical bleomycin 1%, okay, thrice a day for 15 days. Okay, so this is a treatment plan for leukoplakia you will follow. Next question that we have is third, patient came with a severe ulceration. Underline the keywords severe ulcerations involving crusting of lips and large ulcers on palate. All right. Patient was recently prescribed a new brand ibuprofen 2 days ago. That means patient had a history of drug intake. All right. Again, third is there is no associated genital or ocular ulcers. All right. What is the diagnosis? See, we have got three keywords. First of all, severe ulceration with crusting of lips, history of drug intake. Third one, no associated genital or ocular ulcers. All right. So we have got four options here. First, Steven-Johnson syndrome. Second, erythema multiforme. C, systemic lupus erythematosus. D, pemphigus. Okay. Now we can easily rule out option C and D since they are autoimmune disease. They are autoimmune disease. All right. Systemic lupus erythematosus has got genetic predisposition. All right. So we easily ruled out option C and D. Now we are left with option A and B. Now, how will you choose between these options? Both the entities, uh, you can say etiology of the both the entities is drug history or intake of drug. Since it is hypersensitivity reaction, okay, that to type 4 hypersensitivity reaction, okay, and the patient will give you drug history. All right. Now, how will you choose between these two options? So, the third keyword that we have is there is no associated genital or ocular ulcer. All right. There is no associated genital or ocular ulcers. So, our correct answer for this question is erythema multiforme because in Steven-Johnson syndrome, there is extensive involvement of the skin and mucosal, you can say genital mucosa and ocular mucosa. All right. So our answer for this question is erythema multiforme. Now, I'll give you important points of erythema multiforme. So these points are important in MCQ point of view. All right. So erythema multiforme, the pathognomonic of you can say pathognomonic sign of erythema multiforme is target lesion, iris lesion, or bull's eye lesion. All right. And erythema multiforme basically divided into minor erythema multiforme and major, depending on the area of involvement. All right. So minor erythema multiforme involves less than 10% of skin involvement with no with minimal or no oral or mucous membrane involvement. All right. And major erythema multiforme is extensive skin involvement will be there. Extensive skin involvement will be there with mucosal involvement. All right. And in erythema multiforme, which are the drugs which can induce this acute inflammatory reaction? They are sulfonamides, NSAIDs, anticonvulsants, all right, and oxycam derivatives. All right. So these are some important points that you should remember in erythema multiforme. Now, what are the clinical features that you see in erythema multiforme? See, how much crusting of lips happens in erythema multiforme. Okay, the lesions are larger, irregular, and deeper. All right, lips lips are especially involved. Gingiva is rarely involved. All right, and lips becomes eroded. Patients cannot eat, swallow. All right, and there is a blood tinged saliva that comes. All right, after 2 days, after 2 to 3 days, crusting of lips, crusting of lips starts. All right, so these are some main clinical features that you see in erythema multiforme. All right, hemorrhagic crustaceans of lips. All right. Next question is soft X-rays with wavelength of 1 to 0.5 Armstrong are known as. So to answer this question, you should know what are soft X-rays, what are hard X-rays, all right, medium X-rays. Uh, they have given options as stray radiation, secondary radiation, Grenz X-rays, and Bram-Starling radiation. All right. So answer for this question is Grenz ray or Grenz X-rays. All right. So there are four types of, you can say, X-rays that we have. First is super soft X-rays, second soft X-rays, third medium X-rays, fourth hard X-rays. All right. Now, super soft X-rays, according to the name, you can just derive what energy they must be having, and So super soft X-rays have lowest energy with lowest penetration, all right, and wavelength of 1 to 2 Armstrong. They are used to treat superficial lesions, all right, and they have no diagnostic value. Then comes soft X-rays. Now, soft X-rays, the other name for soft X-rays are grains X-rays. Grains X-rays. All right. So they have a wavelength of 1 to 0.5 Armstrong. They are used in contact therapy. What is contact therapy? You can use this in psoriasis, all right, and any dermatological lesions also. Then we have medium X-rays, wavelength with 0.5 to 1 Armstrong. They are diagnostic, okay, diagnostically used and also used in superficial therapy. All right. Then comes hard X-rays. Now, hard X-rays will have a wavelength of 0.1 Armstrong. They have the highest penetration and highest energy. All right. So you need to remember these types of X-rays. They can ask you wavelength and penetration power. All right. Uh, Next we have. All right. So uh, as we see these options, you should know what these terminology means. What are stray radiation, what are secondary radiation, and what are Brahms-Starling radiation. Brahms-Starling occurs when there is an interaction of X-rays. Sorry, interaction of the electrons with the target. Okay. Then stray radiation and what is secondary radiation. You should know the terminologies. First, we have primary radiation. Primary radiation is what? Radiation emitted by the focal spot of the target. All right, is a primary radiation. Stray radiation is a radiation emitted by any part of the X-ray tube other than focal spot. All right, which is stray radiation, not useful. All right, useful beam is what? Is a part of primary radiation which is allowed to emerge out of the X-ray tube, that is collimator. Okay, is useful beam. Scattered radiation is what? The radiation which has undergone the change in the direction during passage through a substance. All right, scattered radiation. Then we have secondary radiation is the radiation emitted by the substance through which X-rays are passing. All right. So just go through these terminologies so that you should have a basic idea about it. They can give you these terminologies to confuse you. Okay. So you just need to know what these radiation means. All right. Next is which of the following disease manifest these appearance shown in the skull radiograph? I told you they will give you a skull radiograph, all right, showing any particular appearance. You should be able to identify which disease manifest as this appearance, all right. Now here in this skull radiograph, if you appreciate, here we have something like this, all right, this opacity, all right. So these are basically a tram line calcifications, all right, tram line calcifications, and these calcifications are seen in which syndrome? Seen in Sturge-Weber syndrome. All right, so our answer for this is Sturge-Weber syndrome. All right, now what is Sturge-Weber syndrome? It is basically a neurocutaneous disease or disorder, all right, and you have the other name for this, all right, other name for this is encephalo trigeminal encephalo trigeminal angiomatosis. All right. So they can give you this synonym also in the options, all right. So you should be able to mark correct answer, all right. Then the you can say characteristic sign of this is Sturge-Weber is port wine stain. port wine stain, which is basically a superficial hemangioma manifest on the facial skin. All right. And this is due to abnormal proliferation of endothelial cells in the arteries. All right. And these calcifications are also a result of this abnormal proliferation of endothelial cells. So what happens is there is a tissue atrophy that occurs leading to calcifications in the medial wall of arteries. Okay, and that can manifest as this tram line calcifications. All right. Now here, option A, I'll just give you the other appearances given in options. Hyperparathyroidism shows you or manifest as ground glass, okay, ground glass appearance or salt and pepper appearance. All right, salt and pepper appearance. Then multiple myeloma, option C. Multiple myeloma will be seen as a well defined radiolucencies, multiple well defined radiolucencies. All right. Hypophosphatasia. Hypophosphatasia will show copper bitten appearance. Copper bitten appearance. All right. So, uh, this kind of questions will be asked most frequently. So, be thorough with this kind of questions. All right. Next question is a 12-year-old girl complains of pain in lower left first molar on eating ice cream. Alright, the pain subsides soon after she stops eating the ice cream. Now, this is a feature of what? This is a feature of reversible pulpitis. Alright, reversible pulpitis. They have clearly mentioned. Alright, now what is the cause of the radiopacity seen at the apex of mesial root of the affected tooth? All right, options are hypercementosis, periapical radiolucency, low grade infection, and osteomyelitis. Now, if you look at the radiograph, you can appreciate here the opacity surrounding the root, mesial root. All right, there is a mesial caries involving pulp. All right, so whenever the patient is having ice cream, she is having pain, and pain will subside after she stops eating the ice cream. That is, cold stimulus will, you can say, exaggerate the pain. All right. Now, by looking at the radiograph, which you should identify the condition that is there here. Okay. So this condition is basically called as condensing osteitis. Condensing osteitis. All right. Now, what is condensing osteitis? It is basically a sclerosis of bone. All right. This is a sclerosis of bone. Sclerosis of bone induced by infection or inflammation. All right. Now, what happens is since there is a caries, the irritants from this infection will cause bone resorption here apically. All right. Irritants from there causes bone resorption. It is called as rarefying osteitis. What is rarefaction? It is bone resorption. Okay. And surrounding it, there is a surrounding it, there is a radiopacity. All right. So what happens is the irritants from the infection will stimulate the bone, you can say, proliferation. Okay, leading to excessive bone deposition here surrounding the radiolucency. All right, and this is called as condensing osteitis. And this condensing osteitis is usually associated with non-vital tooth. All right, or non-vital pulp. All right. So this condition occurs due to what? Due to low grade infection. Alright. This condition occurs due to low grade infection. This is the answer for your question. All right. They can also give you radiograph only and then tell you identify the condition. When there is a such you can say such lesion present, your answer should be condensing osteitis. Now you can get confused between hypercementosis. So there are basically three entities that you will get confused with: hypercementosis, condensing osteitis, and idiopathic osteosclerosis. All right. Now, how will you differentiate these conditions? Now, in hypercementosis, what will you see? Uh, Not necessary hypercementosis is associated with non-vital tooth. It can be associated with vital tooth also. All right. So, in hypercementosis, there will be excessive cementum deposition on the root. All right. Excessive cementum deposition on the root, and the pedial space, okay, will be surrounding this hypercementosed root, sorry. Pedial space will be surrounding this hypercementosed root. All right. Not in the case of condensing osteitis. Look at the condensing osteitis. The pedial space is inside this, you can say, the radiopacity. All right. So condensing osteitis, very easy, associated with non-vital tooth. Okay, there will be caries or some kind of infection that can cause this excessive bone deposition, and you can differentiate these two entities like that. Idiopathic osteosclerosis. Now, idiopathic osteosclerosis is not necessarily attached with the root. All right. It can be lying or suspended in the bone. Okay, like you can say bone island or something like that. Okay. And the tooth is vital. If it is attached to the tooth is usually vital. All right. And it is also idiopathic osteosclerosis is also called as synonyms anostosis or dense bone island. All right. So you can differentiate these three entities, all right, using these some important points, all right. Then we have next question. The OPG of patient shows multiple radiolucencies. Now we'll underline the keywords. Multiple radiolucencies in posterior mandible and maxilla. Second keyword, chest X-ray was pathognomonic. What is the diagnosis? All right. Now you have two keywords here: multiple radiolucencies and I'm sorry, chest X-ray was pathognomonic. All right. Now to answer this question, you should know which entity shows multiple radiolucencies. All right. Which entity shows multiple radiolucencies? So first we have a list of entities: multiple myeloma, multiple myeloma. Second one is basal cell nevus syndrome. I'm sorry. Next we have is a metastatic carcinoma. All right. Fourth is Langerhans cell disease. This is also called as idiopathic histiocytosis. All right. Now, if you look at the option here, okay, if you look at the options here, you have two entities from our list. Okay, two entities from our list. Now we have to choose correct answer for this question. All right. Before that, you should know which appearances seen in the cherubism and Brown's tumor. Brown's tumor is seen in hyperparathyroidism, all right? So, cherubism and Brown's tumor shows multilocular radiolucencies. Multilocular, all right? Multilocular radiolucencies. So, we ruled out option C and D. Now, we have to choose between option A and B, all right? Now, how do we choose between them? They have clearly mentioned chest x-ray was pathognomonic. All right. Chest x-ray was pathognomonic. So there is only one entity which shows lung involvement. All right. Which is Langerhans cell histiocytosis. So the answer for this question should be Langerhans cell histiocytosis. This is basically abnormal proliferation of, you can say, Langerhans cells, and these Langerhans cells get disseminated and involves bone marrow, lungs, spleen, liver, and lymph nodes. All right. So, Langerhans cell histiocytosis is your answer. Basal cell nevus syndrome, you have multiple OKCs seen in that syndrome. All right, multiple odontogenic keratocysts. All right, uh, but there is no lung involvement as such in basal cell nevus syndrome. Yes, there is a you can say bifid rib there, but lung involvement is specially seen in Langerhans cell histiocytosis. All right. Now, Langerhans cell histiocytosis basically uh, divided into three types. All right. Langerhans cell histiocytosis is divided into three types. First is a lateral sieve disease. Second is Hand-Schuller Christian disease. Third is eosinophilic granuloma. All right. Now they can give you these options also. All right. Not in this question, they have just mentioned the common term Langerhans cell histiocytosis, but they can give you these options also. All right. So lateral sieve disease is seen in less than 1 year of age. All right. Hand-Schuller-Christian disease is seen in children and young adults. All right. Eosinophilic granuloma is mostly localized form, and the characteristic feature is, you can say, is proliferative periosteitis. Just remember these terms: proliferative periosteitis. All right. Now, in Hand-Schuller disease, there are three features or entities which can be seen, which is bone lesions. Second one is exophthalmos, and third one is diabetes insipidus. Diabetes insipidus. All right. So just remember these three forms of Langerhans cell histiocytosis. All right. Next question is, artifacts as shown in the picture below are seen in which imaging? Now here, if you appreciate, first of all, you should be able to identify which radiograph is given. All right. So this is basically a axial section of CBCT. CBCT. Now they have here in this question they have asked about which imaging modality. They can ask you which artifacts is seen in the picture. All right. So you should be thorough with all the artifacts. All right. So here our answer is CBCT. All right. And which artifact is there? It is beam hardening effect. Beam hardening effect. And this is basically a introduced artifact. It happens due to metal crowns in the patient. What happens there is the photons, low energy photons, which are coming up, all right, low energy photons gets absorbed, all right, and they causes this distortion of metallic object, distortion of metallic object, all right, due to differential absorption, and you will be able to see cupping artifact and streak bands, all right. So here if you see there are bands coming out of the, or stri coming out of the, you can say this radiopaque structure, that are streak bands. And cupping effect is what? The metallic object or crown, the shape of the metallic object will be distorted due to differential absorption of the photons. All right. So this is basically introduced artifact. All right. Seen in the CBCT. Next question is identify the structure seen in IOPA. All right. So these are most, you can say, very easy question, or very, you can say, very easy to answer if you are thorough with all the anatomic structures seen in IOPAs and OPGs. All right. So here they have pointed out this structure, which is, first of all, you should be able to identify which area is this. This is mandibular incisor region. All right. And the structure which is seen here is a mental ridge. So option D is a correct option. All right. And below mental ridge, we have something, this is a radiopaque structure, which is called as genial tubercle. This also can be asked. And inside which there is a radiolucent, you can say, foramen, which is a lingual foramen. And the radio opaque structure surrounding it is a genial tubercle. All right. Okay. Next, last question for the day. A patient comes to a clinic with a complaint of mild pain and sensitivity in lower central incisor, which is relieved by taking analgesics. On radiographic examination, the following is seen. The lateral incisor was asymptomatic. What is the diagnosis? All right. This, they can give you just a radiograph and then identify the condition, or identify the, you can say, entity. All right. So here you see there is a radiolucency in the lateral surface of the, you can say, lateral incisor. All right. And there are, you can say, grape like structure. All right. So among given options, which option suits best to the radiograph? Okay. First is radicular cyst. Now you should know radicular cyst is basically inflammatory cyst and associated with carious tooth or any infected tooth. All right. So can you see any caries or, you can say, infections involving this lateral incisor? Okay, no, there is no infection or caries. So radicular cyst, not our answer. C, option C is dentigerous cyst. Dentigerous cyst is most commonly seen in mandibular posterior area, third molar area, and it is associated with impacted tooth. Okay, so option C also we ruled out. All right. Option D, primordial cyst, is also associated with unerupted tooth. All right. So we again ruled out option D. All right. Remaining option is option B, which is botryoid odontogenic cyst. This cyst is a variant of lateral periodontal cyst. Lateral periodontal cyst. All right. And this has got grape-like appearance. Grape-like appearance associated with vital tooth. And sides, common sides are lateral incisor and premolar. All right. So the answer for this question should be option B, which is botryoid odontogenic cysts. So these uncommon cysts that is not, you can say, commonly seen in the practice can be asked as a MCQ questions. All right. So you should be thorough with those uncommon cysts and tumors. All right. So this completes our session with 10 important MCQs. Okay, this kind of MCQs can be asked in INI-CET exams. All right, and the topics which I have summed up. Be thorough with those topics. You'll be easily able to answer the questions. All right. So we end the session here. Uh, take care and good night. And all the best for your exams.